Welcome, everybody. If you're tuning in, this is Dr. Tony Tarchichi from UPMC Children's Hospital, Pittsburgh, here with PHM from Pittsburgh, although this week we really should change the name to PHM from Seattle. If you're listening, this is one of our special episodes for the Pediatric Hospital Medicine National Conference in Seattle, Washington, this late July.
As I'm sure you all remember, I sent the email out to the AAP Hospital Medicine listserv asking if anybody had original music or public domain music they wanted to send in. We would use it as intro and exit music for the podcast during these special episodes, just to highlight some of our non-medical talent we have in our hospitalist pool. Well, the song you heard introing us in, and the same song that's going to exit us out, but at different points, was sent in by Dr. Jake Eichenberger. I hope I pronounced that right. And it is him playing the cello, and this is Vivaldi's Concerto in G minor for two cellos. He is playing one of the cellos. Thank you very much, Jake. I appreciated it, and I like the music.
We were asked to put a few of these episodes together specifically for the conference, and this is a part of our Meet the Plenary Speaker series. I am fortunate enough to have with me one of our plenary speakers here. In case you're new to the podcast, we've been going since October of 2016. I'm a MedPeds trained pediatric hospitalist here at the Paul C. Gaffney Division of Pediatric Hospital Medicine at UPMC Children's Hospital, Pittsburgh. We normally go through specific educational topics in hospital medicine, and this week we're doing special stuff for the conference. And I am fortunate enough to have with me one of our plenary speakers who will talk on Sunday, Dr. Basil Zitelli. Dr. Zitelli, we have a brief history about him. He graduated from the University of Pittsburgh School of Medicine. He did 3 years of pediatric residency training at Johns Hopkins, 2 years of service in the U.S. Navy, then returned to Johns Hopkins for 2 years of chief residency. In 1978, he came to Children's Hospital of Pittsburgh to join the Paul C. Gaffney Diagnostic Referral Service, which is a nascent pediatric hospital medicine group. He is senior editor of the Atlas of Pediatric Physical Diagnosis, which is probably, if you're listening, how you know him, it's in the 7th edition. He's a former editor of the Harriet Lane Handbook, that was before coming to Pittsburgh, author of over 135 peer-reviewed articles, book chapters, and reviews. He became division chief in 2002 to 2017 here at Paul C. Gaffney, now Division of Pediatric Hospital Medicine. You may have heard him speak. He's spoken regionally, nationally, and internationally on pediatrics and on multiple topics within pediatrics. So without further ado, Dr. Zitelli, thank you for joining me.
Thank you, Tony. I'm glad to be here. Thank you.
So this is just a Meet the Plenary Speaker series. So now, how long have you been in pediatric hospital medicine, what is now called pediatric hospital medicine?
Well, I came to Children's in 1978, as you pointed out. And I think at that time, although we weren't called hospitalists, that indeed was a hospitalist group. So perhaps one of the first groups doing pediatric hospital medicine. So I have been a pediatric hospitalist for 40 years.
Now, for those listening at home, in all transparency, Dr. Zitelli is a friend of the podcast. He was actually my first interview for the podcast we ever did. So if you will go way back, and please excuse the audio back then because I was new at this, him and Dr. Sarah McIntyre were the first two guests I had on the show. And we have a whole episode there on the history of pediatric hospital medicine. But let me ask you, when you were finishing your chief year at Hopkins, you probably had multiple options of where you could go. You had family in Pittsburgh, but what drew you to this? What drew you to Paul Gaffney to this?
Well, because I had done my medical school training here, and I had an opportunity during my pediatric rotations to work with Dr. Gaffney. And I felt that he was an embodiment of the mentor's mentor, the physician's physician, the pediatrician's pediatrician. Although he was a hematologist oncologist by trade, he was a great mentor and teacher. And I had the opportunity to come back to Pittsburgh and be a part of the two-person group at that time, he and one other person, which was an exciting opportunity for me. And I felt that I couldn't pass it up.
Now, can you give us a brief or a sneak peek into what you're going to talk about on Sunday? Maybe just a title.
Well, the title is Back to the Bedside in the Era of Technology. And all of my career, I have felt, as my two great mentors, Dr. Gaffney and Dr. William Zinkum at Johns Hopkins, that they always practiced the basics, particularly emphasizing the importance of the history and the physical examination. And throughout the 40 years, we have seen tremendous advances in medicine and particularly advances in technology. But with those advances in technology, there have been costs associated with it, and oftentimes leading to a decline in skills, particularly related to the basics of history and physical examination. And so I'm going to touch a bit on my presentation in Seattle.
Now, you recently retired.
That's correct.
How are you enjoying that?
I highly recommend it.
I can't start thinking about it yet. I have a long way to go. In your 40 years here, if we have listeners listening who are either residents, let's say, or fellows, new faculty, is there any piece of advice you wish you knew when you first started that you'd like to give them?
Well, how long do we have?
Well, as long as you want.
I think that just to go back to what I'm talking about is that we cannot underestimate the importance of the history and the physical examination as keys to our entire career. The history and the physical lay the foundation of everything else that we're going to do. And so when I teach medical students physical diagnosis, I try to emphasize to them that without a good history and physical examination, everything else is like a castle built on sand, that it doesn't have a strong foundation. And so you oftentimes may be led astray. And so history and physical examination skills are two aspects of hospital care, medicine in general, that we should continually attempt to improve upon and sharpen our skills. And so I think that that's one of the many things that we should pay attention to.
Now, in your time, you've seen the field of pediatric hospital medicine go from not a field at all to a growing field, to national conferences, and now a subspecialty. What do you think about it all? I mean, watching it develop from beginning till now, seeing it grow, what are your thoughts?
Well, first of all, I'm extremely excited to see this happen. And I think it's important because in my career, I believe that hospitalists have developed a special skill set to care for sick children, that we have an opportunity to interact with community physicians, helping to care for their patients. And it's perhaps, I think, the best of both worlds, particularly nowadays when there's more and more stress on primary care physicians for time management, in which they cannot, for many different reasons, come to see their patients in the hospital setting. I have learned over the 40 years that I have lost my primary care skills. I truly respect what the primary care physician can do in the office and how important they are to the care of their patients. Similarly, I think we have special skill sets that we can provide to the patient as well as to the primary care physician, giving a balanced care for the patient.
So if you were asked now to go back to the primary care office and work, you would want to brush up.
Oh, I think I would want to more than brush up. I would have to completely learn the skill set and learn more about all the primary care problems that these pediatricians deal with on a day-to-day basis.
See, I like how you said that, because far too often we talk about our skill set, but we don't also really give the accolades where they're due for our primary care colleagues who are in the office, who are doing things we don't do and can't do. And then we all somehow work in concert, ideally, in concert and harmony, to take care of the patients wherever they may be. That was very nice. I guess my next question to you is, now you were a division director for 15 years, but even more than that, whenever you're in a room, you have a sense of quality about you of leadership. There are leaders by position, and there are leaders who are just leaders. And we have a series we've been doing on leadership. You mind if I ask you a few questions?
No, go right ahead.
So one of the things I was impressed with when you were, and in all transparency, I think you guys have figured this out if you're listening, but Dr. Zitelli, Basil, was my division leader here when I first got here. And of course, now Ben Miller has transitioned into that role, and he's our division leader here. We were talking a little bit ago about conflict resolution, and specifically within departments. So as a hospitalist in the hospital medicine division, sometimes neurology or sometimes cardiology or sometimes infectious disease want us to do more or something. And you as a division leader or whomever as a division leader may have to decide, is this in the best interest of our division? Can we take this on? What additional resources do we need? How do you go about, before you have the meeting, looking at the ask, thinking about it, and deciding whether or not we should do it, can do it, or what we need to do it?
That's a complicated question. It has many, many different facets to it, as you've alluded to. First is the question or the request reasonable for the division to take on from a manpower point of view, as well as our knowledge base? There are times that we have been asked to take on care of patients in which we have no experience, and regardless of them being on our service, that we would still have to involve subspecialists in the care. Is this a duplication of effort, or are there other services that we could offer the patient by being a consultant rather than having the patient on our service? So that's one aspect of involvement. There are times when we have been asked to take patients on our service with problems that we could perhaps take care of. These are subspecialty patients that we may be able to manage reasonably well. And in that case, we have to look at the number of patients and the manpower needs and so forth. And it may ultimately come down to negotiation with the subspecialty service about how is the best way to try to satisfy the subspecialty service as well as to keep our service in balance. One of the things, of course, we always have to be cognizant about is it feasible or possible that by taking on additional responsibilities that we would be overwhelmed and cut back on our primary mission of general hospitalist care. The bottom line, I think, always has to come back to what is best for the patient. And so negotiations frequently with interdivisional conflict, I think, always has to come back to that. And then that has to be tempered with many of the other aspects that I've mentioned.
When you're in that position, how hard is it to say no?
In general, I think it's very hard to say no. It's very hard to say no because I'm proud of the work that we do as hospitalists. I'm proud of this particular group that I was the division chief for 15 years. I know what we can do. I know that we provide good care. And so in many instances, I want to say, yes, we can do this. But then the other facets and other kinds of things that accompany the request may either force me to say no or, again, as I mentioned, lead to negotiations where we can modify the request.
What would you say your leadership model, how would you describe your leadership style?
I recognize my limitations, and I rely on many people, particularly within the division, helping me, advising me. And so it really is a team effort. On numerous occasions, the departmental and hospital administration have come to us and asking us to take on responsibilities that we cannot say no to. And in those situations, I come back to the group and say, okay, this is something that we need to do. And I rely on the group to help design a way that we can accomplish the goal. This has a result of the group taking ownership. And when people take ownership of a particular project, they see the transparency about it, and they are much more likely to accept and work within the confines of the request. So it's important that we do this as a team. So I think working all together as a team is perhaps the best way to accomplish goals.
And you may not always 100% agree with the model that's presented that we come up with, but you go along with it.
Well, that's correct. I mean, there are certainly times when there is no retreat from the request. And so, again, working within the confines of the request, what can we do that will help us work to make the best outcome? And there are many examples in my 15-year tenure as division chief in which that's come about. And I will definitely say that the best ideas didn't come from me, but came from within the division. And because of that, the group has accepted what was given to them, and it turned out to be much better than ever I could have dictated. So I rely a great deal on the members of the division to help.
And what's so fascinating to me is when you look at comic writers, writers for sitcoms, TV shows, or movies, that's the same style they use, which is everyone in the room throws out ideas, we flush out the ideas, and we come up with a plan that we have as a group. And it seems to work in writing for shows, and it seems to work for what we do as well. It's just the idea that groupthink and groupthink can be a negative term, but a collaborative effort is better than individual efforts always seems to work.
Well, I realize the best thing is to surround myself with very smart people, because most of the time they're a lot smarter than I am. And so they all make me look good. And I truly appreciate what everyone around me has done. And it is I go back to a team effort for the entire division.
And we appreciate your mentoring, and I'm going to ask you about that. So one of the things, we've had Dr. Sperring on, CEO of Seattle Children's, and Dr. Ellen Wald I've interviewed, who's the chair of pediatrics at the University of Wisconsin. And the advice they gave for younger faculty or even fellows who are interested in leadership is join a committee, whatever committee is available that interests you in some way. Take a leadership position and just show effort, show work, get results, and then continue to do that. And the more you do that, the more you'll be asked to do leadership roles. Do you agree?
Absolutely. While I was division chief, one of the things that I was faced with was, should I develop a hospitalist fellowship program? Initially, I was reluctant to do that because although there were fellowship programs scattered around the country, there was no unified curriculum or direction nationally. And it really wasn't until the early stages where the hospitalist group within the American Academy of Pediatrics began to formulate the beginnings of pediatric hospitalist medicine. And Tony, I think you can agree that when we initially talked about you becoming a director of our fellowship program, you were very excited about it, and it was great for you to accept it, and you grew into that position. You initially attended a pediatric fellowship director meeting. You began networking with people, and you just recently told me that you have more and more things on your plate now than you think you can handle.
Yeah, I thought it was a good idea to make a podcast too. That's exactly right. And I remember that meeting. I said, I think we should. I'd like to join this pediatric fellowship directors listserv. And then I said we have a rough draft of a national curriculum we all kind of agree on. And your response was, all right, start making one. Start making a fellowship. That was great. We'll see.
And you've been extraordinarily successful.
Thank you. Now, one of the things you're speaking, a lot of times people look at people who give speeches and say, oh, well, you have to do research in whatever you're speaking on and be a national leader in that research. You do not necessarily do active research in everything you give speeches on. Is that right?
No, I'm a generalist. Okay. And so I have many interests throughout my entire career that I've published on, ranging from pediatric liver transplantation to aspects of child abuse to many other things. And my research really primarily had been involved in pediatric liver transplantation. And I think that was a large part of my academic endeavor. When our time doing liver transplantation was over, is when I started getting more involved in general pediatric issues, and particularly developing the Atlas of Pediatric Physical Diagnosis. And so I shifted gears, and I began doing a lot more speaking on general pediatric issues around the country. So I'm interested in general pediatric research. it's important. So my career has been divided, I think, into three different aspects. First is my intensely academic involvement in liver transplantation. The second being involved in publications on general pediatric issues, as well as developing the atlas. And then more administrative and leadership within the division. So I've been blessed. I say that many, many times. I've been blessed with my career, and fortunately for me, that's how my career evolved.
I'm going to get back to the liver transplant. I have a question about that. But what I want to ask you is for the young faculty, fellow, resident, medical student, or whatever, who says, I may not want to do intensive research in X, Y, or Z, but how do I start giving talks, giving speeches? How do I get to the point where people are asking me to give talk on hospital medicine topics, on general topics, without me having to devote time and get grants and do that research? What advice would you give us to that person who came to you?
Well, that's a difficult question, and I think it depends a great deal on the environment in which that particular person finds themselves. Many academic centers will demand some sort of research experience. And I think for hospitalists, while they may not be in a basic science laboratory, there are many other opportunities for research, quality improvement, for example, and looking at case reports, and also patient populations, doing chart reviews, retrospective information, or even designing or participating in other studies, either headed by themselves or headed by someone else that they are a member of the investigative committee. I think it's important for young people to understand the scientific method and the importance of research. But it doesn't always have to be that they are the ones who are getting the grants. Again, that may be dependent upon the academic center. Many of my talks had evolved from topics that I had little knowledge about, that I was seeing frequently in my clinical practice, that I was confused and I didn't understand it well. And so I felt the best way for me personally to learn about it was to do a literature review and find out everything I possibly could about that particular topic. And so many of my talks stemmed from that. And so starting to talk, within the hospital, expanding to community pediatric groups regionally. And then ultimately that spreads a bit. If you're a good speaker and it's a topic of need by other physicians, then that spreads and the requests will come. And I think that that's, for many of the topics that I've spoken on, that's how it began.
Well, I think that's very practical, good advice. Pick something you're seeing that you're confused about. And to be honest, I've taken that advice for the podcast. A number of the episodes were things I did not know very much about. We had to research them. And of course, I found a good expert guest, because otherwise.
But you had to do your homework.
There's a lot of homework. Always a lot of homework. Now, were you doing liver transplant in the time of Thomas Starzl, the father of liver transplantation nationally, here in Pittsburgh?
Yes. Dr. Starzl came to UPMC in 1981. I had joined Children's Hospital in 1978, so just a few years after I joined. And he wanted clinicians to be a part of the liver transplant team. After several other faculty members declined the opportunity to work with him, the three of us in our hospitalist group, young, I think somewhat naive, young clinicians, said, yes, why not? And so we were thrown into pediatric liver transplantation. And just like I've said about the talks, we had to learn liver transplantation very, very rapidly, and virtually every aspect of it. So in many ways, we had to become experts in liver disease, pathology of liver disease, complications of medications, including immunosuppressive medications. And that really, as I mentioned, became the beginning of my academic life, because I had the opportunity to speak about pediatric liver transplantation, not only around the United States, but it was invited to many countries to speak about the pediatric aspects of liver transplantation. And so published a great deal about that, and still is an area of great interest of mine. I've worked very, very closely with Dr. Thomas Starzl, and it was an area, in time that was extraordinarily rewarding, but extraordinarily difficult.
Is it safe to say you all didn't know what you were getting yourself into?
We were flying up by the seat of our pants on many occasions because particularly with the advent of cyclosporin, very few people knew about how to use cyclosporin. Just anecdotally, I remember in the early days that Dr. Starzl and we were making rounds and concerned about a patient who had what appeared to be rejection, and Dr. Starzl said, we need to get cyclosporin levels. And we had a pharmacologist on our team, and we were able to get cyclosporin levels. And when the cyclosporin levels came back and the patient still was not responding as expected, then Dr. Starzl said, I don't care about cyclosporin levels. And so even with an expert, there was a great deal of ambivalence about what was going on at the time, and we all were on a learning path. In many ways, it was very stressful, but as I said, it was extraordinarily rewarding to see children do well after transplantation and ultimately lead normal lives.
That's amazing. It was from the beginning, in the field, in the ground, working at it and publishing as you go. And probably everything was groundbreaking. Everything was new. Anything you published was a new finding.
That's right.
That's amazing. All right. You're going to be in Seattle in late July. What tourist stuff are you hoping to do?
Well, I'm actually going to be in Seattle for only a brief time with the meeting itself. However, my wife and I will be going to Olympic National Park, which is on the western side of the state. It is a beautiful national park. We've been there a couple of other times, and we're going to be spending a week there after the meeting. So we're looking forward to that as well.
That's great. I hope you have a great time.
Thank you.
All right, Basil, last question before we get you out of here. Now that we know where you're going to be in Olympia National Park. I'll give you the final thoughts. What one piece of advice more would you give to any person in hospital medicine at this point?
Well, I think one piece of advice that has been helpful to me and to many, many other people is never close any doors of opportunity. Take the time to evaluate opportunities that come by. And even though you may not know very much about it, such as liver transplantation in my case, you never know where that's going to bring you. The people that you may meet, the opportunities to learn different skills. And even if it doesn't work out, it's not a wasted opportunity. There may be other doors of opportunity that open up. So don't be afraid to go through that door.
That's great advice. Wonderful advice. Thank you very much. Now, Basil, thank you for joining us today. And we should say that Dr. Zitelli and a few of us here at Paul C. Gaffney Division of Pediatric Hospital Medicine are doing a workshop on Sunday at noon. Will be one of the last parts of the conference. So if you're around, we'd love to see you there. But Basil, thank you very much for joining us. Thank you for being a part of this. For those listening at home, there will be no CME credit attached to this particular episode. This is more of a get to know you podcast. It's hard to give CME credit for this. But thank you for taking the time out, and I hope you have a great time and enjoy your retirement.
Thank you, Tony, very much.